Good afternoon, respected chairpersons and members of the audience. I'm here to speak on heart masses. Well, it's a bouquet of cases. Some are common marigolds, while others are forget-me-nots. Cardiac masses include primary and metastatic cardiac tumors, pericardial and mediastinal tumors and cysts, non-tumor masses, and disorders that mimic tumors, including intracardiac thrombi, vegetation, infiltrative disorders, and iatrogenic bacterials. We are going straight away to the cases. The first case is one of a 57-year-old diabetic gentleman presenting with a history of chest pain 2 weeks back, ECG revealing antiseptal infarct. We can see the kinetic epics, harboring an echogenic mass. So it's a thrombus. Formed thrombus frequently occur in the region of most severe wall motion abnormality, common in the apex. Second case is one of a 48-year-old gentleman presenting with shortness of breath and urticaria with a very high absolute eosinophil count. And here we can see a perfectly contracting left ventricle with few echogenic masses hanging down. Here we can appreciate the mass more clearly, separate from the myocardium. So this was hypoeosinophilic syndrome, in which the apical thrombus may develop despite normally contracting underlying myocardium. Third case is one of a 13-year-old lady presenting with shortness of breath on exertion. She was found to be in AF. Echo revealed severe mitral stenosis, which is an echogenic mobile mass in left atrium. Obviously, it's a LA thrombus, severe mitral stenosis. And this is a similar case where we can see intense spontaneous echo contrast with thrombus formation in left atrium. So left atrial clots are present in a third of patients with severe rheumatoid mitral stenosis with atrial fibrillation. The next case is a 20-year-old lady with recent history of COVID-19 pneumonia and high D-dimer level. She presented with cough and dyspnea, and we found an echogenic mass in the pulmonary artery. A closer look revealed it's coming from the left pulmonary artery, peeping out of it. So it's a thrombus in the pulmonary artery. So according to widespread theory, thrombotic masses in the pulmonary artery are usually because of embolization. But now we know that it can occur primarily in the pulmonary system. Endothelial dysfunction can impair the antithrombotic function of the arterial wall through downregulation of endothelial nitric oxide synthase or via stimulation of adhesion receptor expression. Hypoxia, pro-inflammatory cytokines, or genetic mutations may predispose to thrombus formation in situ. The next case is one of a 60-year-old gentleman presenting with history of fever for 2 weeks. You can see a hint of a mass in the intramitral leaflet, clearly an echogenic mass. So the obvious, keeping the background, we had infective endocarditis in mind, and blood culture was done. This was significant MR. Blood culture revealed the causative organism to be Gemella morbillorum, which is a very rare pathogen. It's a commensal in our oropharynx and gastrointestinal and genitourinary tracts, but it's a rare cause of infective endocarditis. Next case is in a 15-year-old girl presented with history of palpitation and atypical chest pain. Here we can see the mass attached to the posterior mitral leaflet, quite a big mass. There's a scattered MR jet. This mass was excised and it was found to be a papillary fibroelastoma of the mitral valve. Next one is a young gentleman who has history of intravenous drug abuse, presenting with fever for 20 days. Plaques is fine. In the apical view, we can see the tricuspid valve has got a mass, tricuspid valve vegetation. And of course, the culture reveals Staph aureus. Infective endocarditis in intravenous drug abusers frequently involves the tricuspid valve, Staph aureus being the most common etiologic agent. Next one is a 56-year-old lady who came for a preoperative checkup, and she gave a history of shortness of breath for a few months. We found this. We can see a mass in the left atrium moving into LV in diastole, creating LVID obstruction. It's attached to the septum. There is significant LVID obstruction with a mean gradient of 13 and a pulmonary hypertension with a TR gradient of 71. So this was a case of LA myxoma which was successfully treated by surgical excision. Next, 63-year-old lady with a past history of surgical excision of squamous cell carcinoma of left angle of mouth 2 years back, followed by radiotherapy. She presented with a recent history of syncope, and echo was advised. What we found? In the plaques, we can see a huge mass filling up the LA. A closer look revealed, look at the PML. It's so thickened, it's as if invaded by the mass, or rather involved in whatever pathological process is there. That gave me the clue, somehow, that it's not a primary, not like a myxoma. So this is a closer look. Here we can see it clearly. So this patient was taken up for surgical excision of the mass, and it was found to be hilar mass, which had invaded into LA. A partial resection was done. It was only, a partial resection was possible only. It was followed by radiotherapy. HP reported synovial sarcoma, which is a very rare tumor affecting the heart. Next, it was in the hilum, sir. It was a hilum, not in the extremities. So, and this is another case where bedside echocardiography of a 60-year-old gentleman was advised. He's a known case of renal cell carcinoma. And we can see the mass in the right side chamber, right atrium entering into RV in diastole. I apologize for the quality of the video. This is a bedside case, and the recording was done by a phone. Here, we can appreciate it's coming out of the IVC straight away. Through the RA, it's entering into RV. So this is it. So venous migration and tumor thrombus formation are unique aspects of renal cell carcinoma.
In such a case, you have to scan throughout the IVC, because this may protrude from the renal vein through the IVC into the RA.
Yes, sir. And so it's unique aspects of renal cell carcinoma with significant therapeutic and prognostic significance, just as Sir was saying. And this is the penultimate case where a 30-year-old gentleman, I am going to a little bit detail of this, a very unusual case, and a 30-year-old male patient presenting with multiple enlarging facial nodules, persistent cough, shortness of breath on exertion. He had a past history of endobronchial tuberculosis for which he received ATD for 6 months. And this is the plaques view. Here we can see lobulated masses in both the ventricles more clearly. Very unusual. So echo study revealed this thickened ventricular walls with normal biventricular systolic function, mild MR, trivial TR with a maximum gradient of 45, and lobulated intercardiac masses in both ventricles with a chink of pericardial effusion. CECT revealed right central mass invading the mediastinum. Bronchoscopic biopsy revealed non-caseating epithelioid cell granuloma with mixed inflammation. Fungal stains revealed many septed fungal hyphae morphologically resembling Aspergillus species. Excision biopsy of facial nodules revealed histiocyte-rich mixed inflammation with necrosis and fungal elements compatible with aspergillosis. Cardiac biopsy was performed, and it was inconclusive, with showing neutrophilic inflammation. Even though cardiac biopsy did not show fungal mycelia, the characteristic echocardiographic features, demonstration of Aspergillus fungus in the bronchoscopic biopsy, and subcutaneous nodule reinforced the diagnosis of cardiac aspergillosis in this patient. And the last case for this, I must acknowledge to Dr. Adis Ghosh. And this is a very unusual case where a 61-year-old gentleman presented with history of fever of unknown origin for 1 month and with a history of chest pain on exertion, which was progressive in nature, and auscultation revealed an ejection systolic murmur in the aortic area. Repeated blood cultures were negative. And here we can see a very prominent echogenic mass in the LVOT, creating LVOT obstruction. This severe LVOT obstruction. With a mean gradient of 73.7. So round echogenic mass in LVOT creating severe LVOT obstruction with a P gradient of 139 and a mean gradient of 73.7. CT coronary angio was normal. In view of the negative blood culture and significant hemodynamic obstruction to the LVOT, surgical excision was done and the specimen was sent for histopathological examination, which revealed nodular areas composed of thyroid follicles of varying sizes filled with colloid. So it's an ectopic thyroid in the heart, which is called struma cordis, which is very rare. Till 2011, only 33 cases were reported, of which 30, most commonly they were either in RV or in IVS, and only 3 of them were located in LVOT, and this was a later finding in our hospital. Thank you. With that, we come to the end of our presentation.
Thank you, Kaustabh, for presenting a dozen of nice cases. Congratulations for the presentation.
Thank you so much.
Now,
Especially the last one.
yeah, that deserves a special mention. And yeah, thank you so much. Unfortunately, we can't take up further discussion, each and every case merit discussion.